Welcome back to the Oncology Brothers podcast. I'm Rahul Gosain, and as always, joined by my brother and co-host, Rohit Gosain. Today, we're thrilled to have Dr. Petros Grivas from Fred Hutch Cancer Center to discuss some key GU malignancy highlights from ESMO 2024. Petros, welcome. ESMO was exciting to say the least.
Hi guys, very excited to be here. ESMO was super exciting, as you said. A lot of important data, very interesting discussions, presentations, orals and posters. So definitely a very important meeting. And I have to say that for a second year in a row, I think GU cancers were probably one of the most prominent, cancer types in terms of new data. And we had back-to-back, we had another presidential symposium with two GU abstracts. So I'm very excited to see the progress made in the field and the positive impact in patients' outcomes.
Indeed. Well, Petros, welcome. Petros, we have 4 important abstracts to cover today. And as you stated, GU certainly took the center stage, and Dr. Powell's continue to hit home run after home run with these practice-changing studies. And that's exactly the first study we'll talk about from him. That is NIAGARA study in bladder cancer space. And then we'll dive into renal cell cancer with TiNiVO-2. And then closing off with 2 prostate cancer studies, PEACE-3, and an update from CONTACT-02. Petros, you were in fact the discussant for NIAGARA Trial, which we will be discussing here. Can you walk us through the study design and what does it really translate to your clinic today?
Great question. And I want to say that NIAGARA Trial was probably one of the most important trials presenting the entire ESMO Congress 2024, really important data and, in my opinion, practice changing. So let's look at the trial design. We all know that cisplatin-based neoadjuvant chemotherapy is a standard of care in patients who are fit enough to get cisplatin. Probably between 50 and 60% of patients in our practice are fit enough to get cisplatin based on the Galsky criteria that were published in JCO in 2011. And the goals we have had is, number one, to improve utilization of that approach, and secondly, to build upon that. So NIAGARA builds upon that backbone. We have GemCis as the comparator control arm. Patients got 4 cycles of GemCis in the control arm. And the experimental arm, it was the addition of durvalumab, PD-L1 inhibitor, 4 doses neoadjuvantly with GemCis before radical cystectomy, and then up to 8 monthly doses of adjuvant durvalumab after cystectomy, regardless of pathologic response. So it was kind of a perioperative, sandwich approach. The primary point was pathologic complete response rate, but mainly event-free survival. The weight of the alpha was mainly for this event-free survival, and the key secondary endpoint was overall survival. Before I talk about the efficacy, I want to show that the toxicity safety data were as expected. And actually, if you look at the tornado plot, the toxicity was very similar in the 2 arms. So the addition of durvalumab to GemCis did not compromise the ability of patients to undergo curative intent radical cystectomy. So that was reassuring that toxicity-wise, the data looked pretty balanced and similar in the 2 arms. So that's a feasible approach. And we have seen that both in phase 2 trials in bladder cancer, but also in other tumor types like breast cancer, lung cancer, where chemoimmunotherapy is being used. Efficacy-wise, there was a delta about 10% in the pathologic complete response rates from 27% with GemCis to 37% with GemCis durvalumab. The combination GemCis durva had higher path CR rate. You can argue that the path CR rate looks lower compared to what we have seen in other trials. However, there may be many explanations of that. For example, in the denominator, they included patients who elected to not undergo cystectomy. This was about 6% in each arm that were included in the denominator. Also, if you look at the clinical stage, about 40% was T2 and 0, 6% was a higher stage, T3 or T4, and there was about 5% of N1 states. And of course, they allowed patients with GFR below 60 ml per minute. And about 20% of patients, 1 out of 5, had a lower GFR between 40 and 60. These patients usually were not considered fit for cisplatin, but they were included, and they used split dose cisplatin for those patients. And the question is, split dose cisplatin, we use it sometimes with borderline creatinine clearance, but we don't have prospective data about split dose cisplatin, but it's an approach we take sometimes in clinical practice. Overall, I would say the important message is that event-free survival and overall survival endpoints were met. There was a hazard ratio of 0.68 for event-free survival, hazard ratio 0.75 for overall survival. Both of them are clinically meaningful. If you look at the delta at the 2-year point, you have that in that slide. You see it's about 7% delta in overall survival. So you can argue you have to treat maybe 13 or so patients for 2 years to benefit one, but in oncology that's meaningful. So it's an important positive trial. It's the only positive trial for OS evaluating checkpoint inhibitor in the neoadjuvant or adjuvant setting. In this case, it's both neoadjuvant and adjuvant. So I think it's practice changing. Someone can argue that the control arm did not have much access to adjuvant checkpoint inhibition. The trial NIAGARA finished accrual before the regulatory approval of adjuvant nivolumab in this setting. So someone can argue what would have happened if the control group got adjuvant nivo. We don't know the answer. And of course, the access to subsequent therapies in metastatic disease, if someone has recurrence, may have impacted, of course, the performance of both arms in terms of overall survival. So subsequent therapies matter. But at the end of the day, the best data set we have right now in this setting in neoadjuvant or adjuvant immunotherapy is the NIAGARA trial. Data are practice changing in cisplatin eligible patients specifically, not for cisplatin ineligible patients as a different population. And of course, we're waiting to see the regulatory agency decision and review of this data.
Petros, thank you for laying that foundation. This is very, very exciting and impressive, and for a few reasons. About same tolerability when you're checking it with chemotherapy. You have EFS, and importantly, you have OS, so patients are living longer. You brought up that this is practice changing. Yes, we'll wait for FDA approval, but today, outside clinical trial, for the right patient in front of you, would you consider moving forward with this approach in someone that has resectable muscle-invasive bladder cancer and are cis eligible?
I think it's a great question. Personally, I would definitely consider this in my practice tomorrow. I think the question is whether people may want to wait for regulatory approval, which I think it's a reasonable question. I think the data are compelling enough, in my opinion.
Now, but the question always becomes is how much is really IO adding in adjuvant space? Outside of clinical trials, any setting where you would rather let go of IO in post-op space, especially when we saw some updates from Ambassador trial at ESMO 2024, which is use of pembrolizumab in adjuvant settings. And you think if ctDNA would guide your treatment here at all?
Number one, NIAGARA trial was great, and again, in my opinion, practice changing for sure. However, the design of the study, 6 or 7 years ago, it took a combined neoadjuvant adjuvant kind of a sandwich approach and was not able to tease apart the individual contribution of the neoadjuvant phase or the adjuvant phase. Do we need either or we need both? And I made this point in my discussion at ESMO. I think based on the design, we have to take the whole packaged approach, I would say, and to discuss with the patients early on. If they can tolerate, of course, durvalumab, they can continue in the adjuvant phase, regardless of the pathologic response, path-CR or not path-CR. And we're going to see more data in the future to help with this dialogue. Do we have to treat everybody? Because obviously there is a risk of overtreatment here. And I think we will overtreat patients because we do not have reliable biomarkers to help us answer the question of overtreatment or undertreatment. And what we know for ctDNA so far is strongly prognostic. ctDNA negative, especially if it stays negative, this portends very good outcomes. So the disease-free survival and overall survival, these endpoints look very favorable in patients who are ctDNA negative. So it's very prognostic. What we need to find out is whether it's predictive indeed. There is a hypothesis generated in the IMvigor010 trial that we published in Nature a few years ago with Tom Powles and others. We'll look at ctDNA positive patients post-cystectomy, and those patients appear to have benefit with adjuvant atezo versus observation. This is a hypothesis based on a post-hoc exploratory analysis, and this is by hypothesis being tested.
Petros, thank you so much for starting us off with a bang. Of course, there's a lot going on in bladder cancer. Now let's switch gears to RCC, where upfront treatment is either dual checkpoint inhibitors or TKI with IO. But then at the time of progressive disease, re-challenging with more immunotherapy has not shown much benefit. Actually, the only data post-immunotherapy we have is for tivozanib, which showed PFS, and tivozanib is approved in this space, or more recently, belzutifan. That brings us to our study here, TiNiVO-2. Petros, can you walk us through the study design and its findings? And importantly, what does it really mean for us if the disease has progressed in first line to IO or IO-TKI combination?
Thank you. It's very interesting to see the evolution in the field, of course, and the emerging therapy options. And one of the questions we have had for a long time in kidney cancer, and by the way, we have similar questions in urothelial carcinoma, is the question of immune checkpoint inhibitor rechallenge. If someone has progression on a checkpoint inhibitor, does it make sense to rechallenge that patient with another checkpoint inhibitor in the future? And obviously, that's a big question because right now, in clinical practice, people may do it, and the question is it worth doing it or not? So in that context, CONTACT-03 and TiNiVO-2, very similar trials, both presented by Dr. Choueiri. These trials try to answer the question, if someone has prior progression to checkpoint inhibition, is it worth the challenge? And both trials told us the same thing: do not do it. The data from CONTACT-03 and TiNiVO-2 were pretty clear that if the patient has progression to checkpoint inhibition, there is no benefit from re-challenge that patient with another checkpoint inhibitor. And the TiNiVO-2 had a few little bit details and differences compared to the CONTACT-03. One of those questions was, is the immediately prior therapy relevant? For example, if patients had immunotherapy as the immediate prior therapy, is that the reason that the CONTACT-03 was a negative trial? And TiNiVO-2, someone can argue that that trial allowed patients that they may have another intervening therapy. So immunotherapy did not need to be the immediate prior therapy. So that was relevant, I think, because we wanted to have that nuance. And as I mentioned, TiNiVO-2 saw the same thing with CONTACT-03, no benefit with addition of a challenge with checkpoint inhibition. There was some critique about the dose of tivozanib. As you saw in the tivozanib, in the combination arm, it was a lower dose. Yes. And some people were asking, is that the reason that there is no benefit? Because you're using lower dose of tivozanib in the combination arm? I think that's a reasonable question. I don't think we know the answer. If we have a higher dose, would it have made a difference? We don't know. However, in my mind, CONTACT-03 and TiNiVO-2, same result pretty much, that the curves are on top of each other. Personally, my take home is, if a patient in the clinical practice has progression while on a checkpoint inhibitor, I would not re-challenge that patient again.
Petros, thanks so much for summarizing it so well. What's really the key here, as you stated, is that re-challenging with immunotherapy, while on immunotherapy and the progression happened, there is no role now. While if the patient received that in adjuvant setting and the progression happened after, then certainly utilize immunotherapy. To reiterate, the first line, if you are using TKI, we have few TKIs available on progression, and tivozanib is in fact the only one TKI that has been studied in randomized clinical trial post-IO setting. And dose here stands as 1.3 milligram once daily, where 3 weeks on and 1 week off. Now, moving along into our second half, which is stressing into the importance of prostate cancer. The first study we have here is PEACE-3, questioning the role of radium-223 with enzalutamide. Petros, can you please walk us through the study and its findings here?
This is a patient population that might not be that common in the modern era in our practices. As you see in the yellow box on the left, these are patients with metastatic CRPC who were asymptomatic or mildly symptomatic, ECOG PS021, and they had no prior treatment with enzalutamide and no visceral metastasis and have ongoing androgen deprivation. The big question is, you see the breakdown of the patient characteristics. Very few patients, I would say minimal number of patients, had exposure to prior abiraterone, so a prior anti-androgen. So the big question here is, how applicable are the data to the modern era population, where at least in the US, and probably in Europe as well, in other places of the world, a significant proportion of patients receive a novel anti-androgen in the hormone-sensitive metastatic setting. So I think the applicability of this data is a major challenge. And this trial randomized patients to enza alone or enza plus radium-223. Primary endpoint was radiographic progression-free survival with many secondary endpoints, as you're showing. And the data showed that the primary endpoint was met. There was benefit with the combination enza plus radium-223 versus enza alone in terms of radiographic PFS, and there was a trend towards benefit for overall survival. Hazard ratio 0.69 for OS. However, because the two curves cross over, there was loss of the proportional hazards model, so they need to follow these curves longer. The question is, what do you do in practice? I think, as I mentioned before, it's hard to find these patients with no exposure to prior novel anti-androgen. I think someone can argue if you have a very rare patient, for whatever reason, has no exposure to prior novel anti-androgen, the data is reasonable for the combination of enza plus radium if you feed the population of bone mets, usually symptomatic bone mets and no visceral metastases. So it will be a very niche population of patients that the data will be applicable to. And as I mentioned, radium has a role also as monotherapy as well. So it's good to see that and kind of revive our enthusiasm about this drug.
I think one thing to bring up is if you're going to use radium-223 and novel androgen therapy, make sure to use remodifying bone reagents as well here, because the risk of pathological fracture increases when you're combining these two things. And Petros, you brought up sequencing, you brought up what to do if you've been exposed to novel hormonal therapy already. That actually takes us to the next study as well, CONTACT-02, where we're seeing cabozantinib being compared with atezolizumab to a second novel hormonal therapy. Initially, this was presented at GU ASCO 2024. Here we're seeing the updates. If this was to become available, how are you going to apply this in your clinical practice? Is novel hormonal therapy the right comparator arm? What are we making out of this study?
So I think that study is interesting because it utilizes cabo plus atezo, a combination that was tested also in the CONTACT-03 trial that we discussed as context in kidney cancer before for the IO challenge question, separate tumor type and separate setting. But cabo-atezo seems to have activity in metastatic castration-resistant prostate cancer, and this was compared to a second novel anti-androgen. And you can argue that we have data that those patients may potentially have better outcomes with chemotherapy in that setting. Yes. Having said that, with that caveat, I think in the real world scenario, many patients do not need chemotherapy or refuse chemotherapy because of toxicity. And of course, that selection of the control group can impact, of course, the performance of the control group and the trial results. But I think, if we think of real world data, patient preferences, there is probably a role for a niche population with a second anti-androgen. So with that context in mind, the data were initially presented at ASCO GU 2024 by Dr. Agrawal and showed a significant benefit in terms of radiographic progression-free survival at that time with cabo-atezo versus the second novel anti-androgen. And the question was, what about overall survival? That many people were asking for. So the data for OS were presented at ESMO a few days ago, and overall in the whole population, overall survival was not significantly different. So cabo-atezo did not prolong overall survival in the intent to treat population compared to the second anti-androgen. Having said that, if you look at the subset of patients with liver mets, there was this subset analysis showed significant OS benefit with cabo-atezo, hazard ratio 0.68 with patients with liver mets, and if you look at the patient with bone mets, hazard ratio 0.79. So I think it's important to at least look at this data and see what the regulatory agencies will do, especially the population of liver metastases that represent a very difficult to treat population.
Petros, you've covered a lot here. Thank you so much for taking the time to touch on these critical studies with us today. For our listeners, let us go over a quick recap. In today's discussion with Dr. Petros Grivas from Fred Hutch Cancer Center, we had a chance to touch on 4 important studies from ESMO 2024, focusing on GU malignancies, starting off with NIAGARA Trial with chemo and immunotherapy in periop settings, and then immunotherapy followed after surgery, which not only improved PFS but also improved overall survival for our patients with resectable muscle-invasive bladder cancer. This should now, in fact, be the new standard of care for this selected group of patients. We then had a chance to touch on TiNiVO-2 study that confirmed rechallenging with more immunotherapy after upfront exposure to immunotherapy is not an ideal approach. Perhaps single-agent TKI such as tivozanib or options such as everolimus or belzutifan should be considered.
In the second half of the discussion, we focused on 2 studies for prostate cancer. PEACE-3 using enzalutamide with radium-223 showed improved PFS. Another study in this space was CONTACT-02 using cabozantinib and atezolizumab, where we saw improved PFS, but the overall survival was not significant. ESMO 2024 was indeed exciting. Thank you for joining us. Make sure to check out our other highlights on breast cancer, lung cancer, and GI malignancies from ESMO 2024. We are the Oncology Brothers.